Good evening, everyone. I welcome you all again in this episode of 4D 2.0, that is detailed discussion in diabetes and its complications. Today we'll be talking about a complication which is not only associated with the mortality but with significant morbidity as well. It is one of the most problematic complication of diabetes. Whenever a patient of diabetes present to us with a foot infection, we are worried about the patient, how to save the foot, and it becomes more problematic if our patient has other complications like uh, cardiovascular problems or nephropathy. In that situation, the problem becomes even more problematic. For today's discussion, we have a very senior endocrinologist. I welcome Dr. Krishna Reddy Thaduri from Kondapur. He's MBBS and MD from Osmania Medical College. He did his MD in pediatrics from Osmania Medical College and then DM in endocrinology from Gandhi Medical College. And in his endocrinology program, he was a university topper, and he is also a winner of YC Mathur gold medal quiz. He has multiple publications to his credit, and he was also a sub-investigator for Tregopil study for oral insulin. Welcome, Dr. Krishna Reddy. Uh, I welcome you for your deliberation. Please go ahead.
We'll be discussing today regarding the food complications. We are seeing complication as a type 2 diabetes in our day-to-day practices. This is basically a very troublesome complication, so which requires sometimes urgent attention, sometimes amputation, sometimes a prolonged course of care that needs a burdensome to the patients coming in the wheelchairs and coming daily for the dressings and infection treatment, daily debridements, painful procedures. So that's why we need to prevent these complications before occurrence. So that is our main motto for today. So the introduction. So we all know that the statistics of the diabetes in India. So almost 10 crores of the population in India has been suffering with the type 2 diabetes. That is almost equals to 10% of the population. And in the of course in the 50 more percent of the people are they are not being diagnosed with the diabetes, but still without a diagnosis they are roaming in the country. So that is also worrisome data. So this diabetes and food complications is generally seen in the prolonged hyperglycemic patients in as a part of the diabetes complication. So mainly the pathophysiology behind is the neuropathy as well as the vascular disease. So this will lead to the foot ulcerations and the high risk of the sepsis, poor wound healing because of the vascular insufficiency as well as the poor glycemic immune deficiency. This may end up in the limb amputations. So if you look at the limb amputations, almost 70% are due to the type 2 diabetes. Diabetic neuropathy is often is the most commonly seen in our day-to-day practices. Almost 70 to 80% of the type 2 diabetes. So almost every patient of the diabetic foot ulcer, they have some component of the diabetic neuropathy. Up to one third of the diabetic patients, they may suffer from the diabetic foot ulceration during their lifetime. So this is very common. We should not ignore it. If you ignore it, they may land up in the limb amputations. It's almost accounting for the 7 to 11% of the hospital admissions in diabetic patients. The similar epidemiology, global epidemiology is like foot ulcers ranges from 1.6 to 8%. These diabetic foot ulcers are the most common in men than women, in type 2 diabetes than in type 1 diabetes. The recurrence rates is quite high. So at the end of 1 year, there is a high likely chance of around 60% of the recurrence. The value reaches 40% within a year and 65% within 3 years. So any patient with a previous history of ulceration, we should be very careful. So they are the patients more commonly, they will go for another ulcer formation and may land up in the amputations. The classification and staging. So there's various stages, various classification systems are available. So based on the natural history, whether it's a normal or high risk, ulcerated, cellulitic, necrotic, major amputation, but doesn't give much data. And Wagner's classification, this is gives us some clinical useful data, which type and which of the complications are present in that ulceration. So Wagner's classification grade 0 will consider as a intact skin, but is going to ulcer formations risk is high, and that's mostly cons or some foot thickening, some areas of the tropic changes. Grade 1 is superficial ulceration. Grade 2 is a deep to tendon, bone, or ligament appearance on the ulcer bed. And grade 3 is osteomyelitis. This involvement of the bone with infection. Grade 4 is the gangrene of the foot and forefoot. And grade 5 is the gangrene of the entire foot. The main pathophysiology of diabetic foot ulcer, as we discussed, so and a background of hyperglycemia, it's a peripheral neuropathy as well as peripheral arterial disease. Hyperglycemia, this will cause immune dysfunction, disorders of the collagen formation. There's inflammation in the vascular endothelium and decreased inflammatory response, and angiogenesis also poor. So, on background of this, if the patient is developing neuropathy, so in terms of sensory neuropathy, so there's a loss of protective sensation. Many patients will be seeing in our day-to-day practice with burns on their feet when they went to the pilgrimage, especially in the summer months, and even hot water burns also very common. This is mainly because of the lot of loss of protective sensation. So even thorn picks and other deep injuries with the small needles and nails. So this is also common mainly because of the loss of protective sensation in the foot. If the motor components also getting involved, so there is a weakening of the muscles, which will lead to the bone deformity. So once the foot arch is gone, there is a more pressure points in the other areas, which may occurs before the onset of the ulcerations. Because of the autonomic neuropathy, the hydration aspects as well as that skin will become dry and no sweating, no moisturization to the skin naturally. So this more prone for the cracks and the fissures, so which are the good beds for the ulcer formations. And especially in these conditions, poor arterial supplies to the limb. So mainly because of the atherosclerosis, so which is a diffuse, which is accelerated by the hyperglycemia, and which will lead to increased oxidative stress, which will result in the inflammation in the lower limb and microcirculation as well as causing the ischemia, which is also acts for the nidus for the infections. So all this together will cause the diabetic foot ulcerations. And the classifying as high risk, moderate risk, low risk as important, because how to proceed in future and how to prevent the limb loss. So all this will be decided how urgently this patient requires interventions. So the classification is mainly whether it's urgent, that is means active pathology. The main indications are any signs of the open wound with or without infection, and new neuropathic pain or pain at rest, signs of active charcot deformity. So there is a midfoot collapse with the swelling of the midfoot, vascular compromise, the sudden or the absent of the deep pulsations, dorsal spades pulsations, all gangrene formation. So these patients, whenever you see in the OPDs, so he needs an immediate referral to the foot care specialist, where a team of doctors will be involved, and the follow-up will be determined by the specialists like endocrinologists and vascular surgeons. And the high risk category, based on the ADA category, KDA category 3. So this is the presence of diabetes with a previous history of ulcer or lower extremity amputation. So any patient, these are the patients who are high risk for the further ulceration and further amputation. So they need a strict follow-up, every 1 to 2 months follow-up needed. Chronic venous insufficiency also will increase the risk of ulcerations because of the edema, skin color changes. If these signs are also there, they require a high risk category, and they require a little bit next available OP referral we need to do for the specialist. Moderate risk category, that is ADA risk category 2. So here, peripheral artery disease with or without any loss of protective sensation, or absent dorsalis pedis pulsations, and the presence of the swelling or edema. So these are also some of the signs that will classify as a moderate risk. So these patients should be referred within next 1 to 3 weeks. and they should be regularly followed with every 2 to 3 months. Low risk category. So these patients loss of protective sensation with long-standing and non-changing deformity. Patient requires prescriptive or accommodative footwear. So these patients require within a month refer to the specialist, and they need to be regularly followed up every 4 to 6 months. Very low risk group, that is ADA category 0. So there is no problem with the sensations as well as the blood circulation. Patient seeks education on topics such as routine foot care and athletic training, appropriate footwear, or injury prevention. So these patients can be referred in the coming 1 to 3 months, and at least annually, these patients should be screened for any development of the neuropathy with the loss of protective sensation. So mainly that is the discussion. I may be touching some of the few points on the therapeutic strategies for the diabetic management. So early initiation of combination therapy, this is an approach to achieve the glycemic goal, because earlier the glycemic control, better will be the future risk of reduction in the complication, what we call it as a metabolic memory and long-standing memory. So in the initial phase of type 2 diabetes diagnosis itself, if you tackle the situation with if required multiple medications and active intervention, lifestyle intervention, if his sugar controls are much better in the earlier stages of the diagnosis, so there will be delay in the complications onset in the future. Novel medication therapies, which are fortunately, which has some of the agents have lost their patent, and so many medications are available as a handful of medication to be treated by the physicians now. Diet and exercise to control blood sugars, along with DPP-4 inhibitors like sitagliptin, linagliptin, alogliptin, and vildagliptin. SGLT2 inhibitors like dapagliflozin, canagliflozin, empagliflozin. GLP receptor agonist. So this is also available to restore the incretin function. So I will discussing one slide regarding SGLT2 inhibitor and DPP-4 inhibitor. So they complement each other in terms of the mechanism of action. So that's why better control of the patient and minimal side effects, because both the agents are safer. The risk of hypoglycemia is very minimal. Both the agents are beneficial in terms of weight loss benefit. So which is the main pathophysiological drive for the type 2 diabetes onset, and they also complement each other in terms of reduction of urinary tract infections and caused by the SGLT2 inhibitors. So there may be a reduction. So SGLT2 inhibitor mainly acts by increasing the glycosuria, increasing the beta cell sensitivity, and increasing the glucagon. And DP4 inhibitors, there's indirect effect of increasing the endogenous GLP, so which will in terms cause the increasing insulin secretion and decreasing the glucagon levels. So overall, the effect will be a reduction in the hyperglycemia, reduction in the weight, reduction in the systolic blood pressure, and weight neutrality by the DP4. So overall combination therapies also, you can reduce the weight. And in the management of type 2 diabetes, these two agents in combination, especially which is right now marketed as generic medications like dapagliflozin and sitagliptin, they're well tolerated and leading to a clinically meaningful reduction in glycemic parameters and body weight that was sustained throughout the 48 weeks of treatment. So this is another article showing that DP4 inhibitors and wound healing effects. So DP4 inhibitors show a promise in the local wound healing of diabetic foot ulcers, in addition to its already established glycemic control. Another trial has also similar findings, improved wound healing of diabetic foot in 3-month randomization trials.
Thank you, Dr. Krishna Reddy, for a very detailed presentation. We have a few questions for discussion. So, Dr. Reddy, what risk factors do you look for in your patients to where you want to look for diabetic foot problems? So, what are the risk factors in a patient that you look for?
Mainly, we should assess patients at least once in a year, even though they are doing good on glycemic control and without any symptoms of the neuropathy. So, better to screen all these patients for the risk factors like neuropathy. So, with the biosensometers and vibration testing with 120 Hz or 10-gram monofilament test. as well as the vascularity sufficiency also will be established by checking the angiobrachial index. So this is also a clinical easy tool to be done in the OPD basis. So angiobrachial index should be ideally more than one. So that means there's a good vascular supply to the lower limbs. Uh, and As well as we should look at the any previous history of the ulceration scars and any history of callus formations, pressure points in the foot, and the glycemic control. How is the glycemic control? So all this we need to be checked in these patients for the risk factors.
Yeah. Thank you, sir. Any guidelines about screening of foot problems? How frequently foot? You did say that it should be done at least once a year, and should it be done at every checkup, or can we tell our patients some tips where they can self-examine their feet? Uh, any guidelines on this?
So basically, the based on the classification, whether they are going for the high risk category or emergency category or mild category, moderate category. So this mild category patients who doesn't have developed any issues of loss of protective sensation or any vascular insufficiency. So these patients can be checked annually, and any patients with a little bit higher risk, especially high risk of any previous ulceration. So these patients should be examined once a month. So based on the severity, we can advise the patient for the follow-ups, and patient also should be involved in the day-to-day screening of their foot for the any pressure point formations and conformation, fissure formations, and any initial ulceration cracks development. So they should examine the foot daily, and they should wash their foot daily neatly with the lukewarm water. And before washing, they need to check the temperature. That is very important. Sometimes, because of the loss of protective sensation, this hot water may burn their feet, and there may be formation of the foot ulceration. Recently, I came across a patient who stepped on a bleaching powder and have a development of the rash. So fortunately, she came early, so we have been treating with her the prevention of the ulcer formations. So regularly checking of the foot is a daily practice for the all type 2 diabetic patients.
Thank you, sir. You talked about glycemic control. So it's a very common question that is being asked to me from our physician friends is, do we always need to shift these patients on insulin even if your patients are well controlled on OHAs? Do you always like to shift these patients on insulin?
Not all the patients, because sometimes very mild patients who are on maintaining with the oral diabetes in the lower doses, they are able to maintain their glycemic control. For example, less than 7, ideally less than 6.5, they are able to maintain without any risk of hypoglycemia, and there is no increase in the creatinine level. So they can be continued on the oral medications, because most of the time these food complication patients, they'll be having either proteinuria and heart related issues, other macrovascular complications. So in those scenarios, if the control is not good, then ideally we should shift to the patient to the insulin therapy. So there is also a saying that insulin will help in the wound healing and other properties. So sometimes we'll be shifting the patient to the insulins.
Continuing this question further, any medications that we need to avoid specifically? These medications should not be continuing. Anything that you like?
So based on the other comorbidities, but especially talking to the foot ulceration, there is only one drug. It has been offended previously, but nowadays it has been proven it's not causing any increase in the risk. This canagliflozin, which was in the initial studies, it was causing the increased risk of diabetic foot complications. Then later meta-analysis has proven that this only safe.
Any preventive strategies that you tell your patient that this is how you can prevent the development of filling your feet is one part. Strategies that your patient can.
Prevention is always better, as we are discussing. Mainly, the glycemic part is most crucial. So, initial part of the glycemic control, as we are discussing the legacy effect. So, in the start of the diabetes onset itself, if you control the proper glycemia, the future risk of these complications will be minimal. And once this neuropathy has been set in and vasculopathy has been set in, so there's a lot of responsibility on the patient as well as the treating physician to prevent the onset of the ulceration and prevent the loss of the foot. So from the point of the patient, so he needs to check his foot regularly and wash regularly, daily wash his feet with the lukewarm water after checking the temperature, and immediately you should dry it out. So if you keep moisture in between the fingers or toenails, so there is a formation of the ulcerations as well as the fungal infections, so which can cause initiation of the ulcers. And along with that, the footwear is also important. Many people, they may be having a deformity of the foot, and they have their pressure points will be different, and which may cause the future formation of the ulceration. So they need to have a proper footwear, protective footwear. So not too tight, not too loose, and at least 1 inch gap should be there for the tip of the toe to the tip of the shoe. And always they should use the protective shoes, and especially inside of the house or outside of the house. So we don't know when they're going to fall, when they're going to injure themselves. So always, ideally, they should wear the footwear. And socks also, they should change regularly. So if you keep on using the wet socks or other socks, so there may be moisture formation and other things. And if especially dry skin people, so they need to apply the moisturizers to prevent the cracks and to moisten their foot. So these are the general guidelines we'll tell the patients.
Just to add on it, so where I live, it's we have a very extremes of temperature. Like during the end of June, the temperatures were somewhere around 48 to 50. We have temperatures as low as 2 degrees, 3 degrees. So we have extremes of temperatures here. So what happens
Okay.
at my place is during winters, people keep their feet in front of heaters. Patients who had deep ulcers on their foot because of the heat after, they actually had a burn injury in these patients. And during summers, many of our patients go for pilgrimage, and they walk barefoot. Again, we have seen such ulcers. So like you were telling, always wear some protective while you're outside or inside house. And this is one thing that I tell my patients, that do not keep your feet in front of heaters or any other thing. And if you're taking a bath also, just ask someone else to check the temperature of the see the temperature properly. So these are the things that we tell our. Thank you, Doctor. So we have talked about education. We have talked about glycemic control. How frequently do you use radiological investigations such as magnetic MRA or CT angiography or just scans in your patients for how frequently do you use these investigations?
Majority of the times we'll be using that acute index as well as neuropathic evaluation. And sometimes this ultrasounds to look at the waveforms of the where is the blocks exactly, and how is the vascular, especially if this ABI is positive, when patient is having any signs of gangrenous changes or vascular insufficiency or absent dorsalis pedis pulsations. So these patients will tend to do that ultrasound investigations as well as CT angiography. MRI I generally won't do. So these two investigations I'll be doing.
Use mainly ABI, and we do frequently use X-rays as well. And very few of our patients require CT angio
Yes.
if we are planning for some sort of amputation. We
Yeah.
have talked practically about everything, but I believe one of the most important things that needs discussion is nutrition, because if our patient's nutrition is not up to the mark, probably the wound will not heal. Any comments on dietary recommendation and nutrition in these patients?
Not only food patients, all the diabetic patients, they require a proper macronutrients as well as the micronutrients. And especially in terms of micronutrients, so they require a good amount of antioxidants like vitamin A, C, as well as vitamin E, and vitamin D also proven in some studies with repair of the wound healing and other things. And another important vitamin we need to discuss is the B12 vitamin. So, which is one of the most common deficient, and sometimes because of the metformin therapy or because of the vegetarian diets. So, because of the B12 deficiency, there is a high chance of the neuropathy as well as loss of protective sensation and more ulceration formations. So these people require a good diet, balanced diet, which includes all carbohydrates, proteins, as well as lipids, but in a proper portions, in a complex carbohydrates and good amount of protein. Most of the Indian diets are lacking the proteins, and we are all most of the time carbohydrate eating populations, so which will in turn lead to the more hyperglycemia and more complications and more infections. So diet composition should be balanced as well as micronutrients and vitamin composition should be well maintained in that.
Dr. Krishna, any last message for our audience? Just your last message.
Yeah. So limb is very, very important. So many patients I have been seeing in day-to-day practice because of the ulceration, they are not able to walk and their sugars are shooting up. They leads to further complications, and this ulcers also takes a very, very longer time to heal, and sometimes they will get infected and gangrene changes and amputations. And so the life will be changed a lot after a ulceration for the type 2 diabetic patients. So we should be very careful in early detection of the people who are at risk of ulceration before the ulcer formations, so that they can take care of their glycemic control as well as the cholesterol control, avoidance of the smoking, lifestyle changes, and protective footwear and daily foot examination, and regularly checking with the physicians for their angiobrachial index and neuropathy checking. So all these are very, very crucial in preventing the patient from going to ulceration as well as to amputations, so which is very important in type 2 diabetics patients. These patients also they are more prone for the other complications like CKDs and heart diseases. So we need to screen them regularly for all these complications and treat as in a comprehensive manner.
Thank you. Thank you, Dr. Reddy, uh, for a very detailed discussion. And with this last message of prevention is better than cure,
Yes.
I believe this is what we want to pass to our audience, that if we are able to prevent one ulcer, probably we are a lot of life years to our patient's life.